bit what this is chromosomal analysis, also called karyotype. So the karyotype is the picture of a person's chromosomes, and it helps us to determine the chromosome complement of this person, including the number of chromosomes and the structure of these chromosomes. The chromosomes is nothing else than our DNA, extremely compact, and the chromosomes are only visible with the cell is going to divide, with the cell is in mitosis. So in fact, the karyotype is the picture of our DNA in a specific point of the cycle cell division. The karyotype is organized in 23 pairs of chromosomes, and we organize them according to the size. And the main difference between karyotype of male and female is that male, they have one chromosome X and one chromosome Y, while female will have two chromosome X. So obtaining the karyotype, it's quite a simple procedure, and it's not very difficult to achieve. We can do the karyotype in a lot of different cell types and different tissues. The only condition is that these tissues, these cells should be alive, because we need to perform a culture in order to get cell division. So for example, if we are doing the karyotype in blood, we only need a little bit of blood, culture this blood, and we are going to sacrifice or stop this culture and stop the cell division. We are going to spread these cells in one slide, and we are going after staining of these slides, we are going to analyze the karyotype, the metaphases with the chromosomes. So we can have a completely normal result in the karyotype. If you are a man, you have 46 XY. If you are female, you have 46 XX. But also we can detect an abnormal number of chromosomes. That is what we call an aneuploidy. We can have extra chromosomes or missing chromosomes. For example, embryos or fetus with extra or missing chromosomes, usually they are not, or most of these extra missing chromosomes, they are not compatible with life, meaning that these embryos are not going even to implant, or if they implant and develop, this fetus most probably is not going to arrive to the term of the pregnancy, okay? Only very few aneuploidies are viable and can survive till birth. One classical example is trisomy of chromosome 21, a person with three copies of chromosome 21, that this is causing Down syndrome. People with abnormalities in sex chromosomes, in chromosome X, in chromosome Y, aneuploidies, meaning they are having extra chromosomes of these two pairs, are usually, they are not having usually major malformations. They don't have intellectual impairment that in other syndromes like Down syndrome, but what they suffer is from infertility and miscarriages. These patients are usually diagnosed only when they are planning to have family because of the infertility. Another type of abnormality that we can detect in the karyotype is what we call structural abnormalities, meaning that we have the correct number of chromosomes, but these chromosomes just have abnormalities in the structure. For example, we have here reversing translocation, meaning that two chromosomes just fuse for this part that we call centromere, or one chromosome has one piece inverted, or just that two chromosomes interchange some part of the DNA. Persons that are carriers of these abnormalities, usually they are completely normal. They have no disease, they have no sign, because they are carriers of this abnormality in a balanced way, meaning that the only thing is that they may interchange DNA from one chromosome to another, but they don't have missing or extra DNA. So they are completely normal. And these carriers usually are completely normal. They don't have any symptom. The only thing that they can suffer from infertility and recurrent miscarriages. So we know, for example, that when we analyze male infertility, around 50% of these cases of male infertility, they have a genetic cause. And we can see here that abnormalities in the karyotype are very frequent. If we are classifying the patients according to abnormalities in the sperm parameters, we can see that, for example, chromosomal aberrations and Klinefelter, that is an aneuploid in the karyotype, it can be as high as 25% of the cases. Regarding numerical abnormalities, for example, in male infertility, we have that Klinefelter syndrome is the most chromosomal disorder related to male infertility. These patients, they have 2 chromosome X instead of 1 and 1 chromosome Y. So the karyotype is like that, 47XXY. The clinical presentation, they can have hypergonadotropic hypogonadism, gynecomastia, small testes, and an increased stature, but it's very variable between patients. We can have also this Klinefelter syndrome in a mosaic, meaning that in the blood of this patient, we can find some cells that they have this complement to chromosome X and 1 chromosome 1, and some other cells that are completely normal with only 1 chromosome X and 1 chromosome Y. And usually the phenotypic affectation it's less severe in these patients with mosaicism. We know that the vast majority of these patients with Klinefelter are azoospermic, meaning we cannot find a sperm in the semen sample. But in some of these patients, around 60%, 65% of them, we can obtain a sperm by testicular extraction. The other type of abnormalities that can affect infertile men are the structural abnormalities. That this can include any kind of structural abnormalities, deletion, duplication, inversion, translocation, etc. And it has been detected that this kind of abnormalities are more frequent in infertile male, and around 5% of them, compared with the general population. And these abnormalities can affect the fertility in 2 different ways. The first one is by impairing sperm production, meaning that during the spermatogenesis, when the sperm are produced, these abnormalities can interfere in some way, and this spermatogenesis, the production of this sperm, can be affected, and usually can be related to oligospermia, or in some extreme cases to azoospermia. Another way of affecting infertility is that maybe this patient can have a completely normal sperm sample, but they can transmit this abnormality in an unbalanced form to their embryos, giving to IVF failures, miscarriages, or babies with disabilities. The patients, as I told you, the patients that are carriers with structural abnormalities, they are completely balanced. They don't have any extra or missing DNA, okay? They are completely balanced, but they can transmit this structural abnormality to their children in an unbalanced form, meaning that these embryos or these babies will have partial aneuploidies, partial extra material or missing material of some chromosomes, and this can give, maybe these abnormalities are not compatible with life, or they can cause severe disabilities. For women, we have more or less the same. Also, aneuploidies in the sex chromosomes and structural rearrangements are an important cause of male infertility. We have, for example, for numerical abnormalities, one of the most common ones is the Turner syndrome. In patients with Turner syndrome, they only have one chromosome X instead of having two. So the karyotype is 45X. The clinical presentation also can be very different from one patient to another. We have severe phenotypes with short stature, premature amenorrhea, low estrogen levels, or phenotypes that are considered mild. Around 25% of these patients are not diagnosed until the adolescence. We can find this monosomy in all the cells, also combined with some cells that are normal, we call mosaicism, or there are other forms of Turner. But at the end, what they are producing is a lack of an essential part of one chromosome X. And we need both to be completely normal. Also, only spontaneous pregnancy occurs or can be achieved in around 2–4% of these Turner syndrome women, and in the most of these cases they are mosaics. They are having also normal cell lines. Regarding structural abnormalities, it's a little bit, it's quite similar to male infertility. We can include deletion, duplications, translocations, inversions. The incidence of these abnormalities in infertile women is higher than in general population, but usually they are affecting the fertility of this woman only by the way of transmitting the abnormality in an unbalanced form to the embryos, to the offspring, causing AVI failures, miscarriages, or babies with disabilities. Usually, in women with these structural abnormalities, in these cases, the oogenesis, the production of the eggs, it's not impaired by these structural abnormalities, and sometimes it's happening in males. So, as I told you, all these abnormalities in the karyotype can cause consecutive or recurrent pregnancy losses and also recurrent IVF failures. Although these recurrent IVF failures and pregnancy losses can have a lot of causes. One of the causes is that one of the members of the couple, can be the male or the female, doesn't matter, are carriers of a structural abnormality, typically a translocation or an inversion. In published studies, we saw that the frequency of chromosomal abnormalities in couples with recurrent miscarriages can be as high as 12%, and more or less all the published works are finding a similar number. General population risk of miscarriages for a recognized pregnancy it's established in around 15%, but in carriers of translocation, this risk of miscarriages can be as high as 50%. In this publication that they analyzed more than 1,000 first trimester miscarriages, they are karyotyping them by analyzing the placenta, the chorionic bili samples. They found in more than 5% of the fetus that they have structural rearrangements. This number is quite similar to other series published previously. From these structural rearrangements, only six were previously known by the family, and the remaining 31 cases were unexpected findings, meaning that one parent of this fetus was carrier of this structural rearrangement, structural abnormality, without knowing it. And this couple in the next pregnancy also is at risk of having another miscarriage for an unbalanced structural rearrangement. So how this works more or less, because patients, for example, in that case, I put an example of a patient carrier of a reciprocal translocation. These patients, naturally, they have chances of having normal babies, okay? Because they can produce normal gametes, normal eggs, and normal sperms that are after fertilization, they will give normal or balanced embryos, completely normal. Some of them can be carriers of the translocation as the affected parent, but they will be normal with no syndrome or with no disease, okay? But depending during the gametogenesis, the spermatogenesis or the oogenesis, depending on how this chromosome segregates, meaning how they are distributed in the gametes, we can have a lot of combinations, okay? From all these combinations, for example, imagine there are sperm, from all this sperm that we can have, only 2 of them after fertilization will give you a normal embryo. All these sperms will give you after fertilization an abnormal baby with an abnormal fetus, sorry, with extra or missing DNA. For example, we have here an example. We have a father with a translocation between chromosome 17 and 22, meaning these 2 chromosomes interchange DNA. This father is balanced, no missing or extra DNA, and he's completely normal, okay? But he had a son that was alive with this karyotype. This son was having an extra chromosome, okay? 47 chromosomes. What happened? In that case, these men produced this kind of the sperm that after fertilization give this karyotype in the son, okay? The son is having this extra chromosome that is this one here from the father. So this boy is unbalanced and was having intellectual disabilities. In that case, I put another example of a Robertsonian translocation, meaning this man, it's also a man, but it can be a woman, there is no difference. This man is having 1 chromosome 13 and 1 chromosome 14. They are attached together for this centromeric region. So in fact, this man, although it's having a karyotype of 45 chromosomes, he's completely normal because the other missing chromosome 14 here is attached to the 13, so he's completely normal. Also, during the spermatogenesis, he can produce different kind of sperms. Only 2 of them will be balanced, will give a normal fetus with no extra or missing DNA, and all the other forms after fertilization will be an abnormal or unbalanced embryo. In that case, these men have a child, and in this case a female fetus, after the fertilization of 1 sperm with this form here, that is having a trisomy 14, okay, because we can see 2 chromosome 14, and the 3rd chromosome 14 is attached to chromosome 13. This was a termination of pregnancy, but usually trisomy 14 ends in miscarriage because it's not compatible with life. So I focus in this talk about karyotyping and chromosomal abnormalities, but obviously there are other genetic causes of infertility for male and for female. So we have abnormalities in the karyotype that they can be easily detected in a karyotype in blood. Okay, it's an easy and usually not very expensive test to perform. But also we have other genetic abnormalities that can impact or can cause infertility in male. For example, in male we have Y chromosome microdeletions that are deletions of a small part of the chromosome Y. These deletions cannot be detected by karyotype, and they need a specific test to be detected. And these chromosome microdeletions usually are related to azoospermia, causing azoospermia. So in a patient with azoospermia, usually what the doctor is recommended or requesting to them, it's to do a karyotype test, but also test this Y microdeletion, Y microdeletions test. Also, we have other genetic disorders that can cause or can, one of their signs can be infertility. For example, we have Carter syndrome that it can be caused by mutation in different genes, but the main characteristic is that these patients, the cilia are not working, so they are not moving. So these patients, since they are very young, since they are born, they have a lot of respiratory problems, a lot of infections, and a part of other things that they should be treated. And additionally, in men with this syndrome, they have infertility because the sperm, it's not motile. The sperm is not moving since the tail of the sperm is moving, so they cannot achieve a natural pregnancy. Okay, this is an example. Another example can be cystic fibrosis. Cystic fibrosis, it's a severe or can be a severe disease, affecting also lungs, pancreas, and other organs that should be treated. But also, one of the signs is congenital bilateral absence of vas deferens, meaning there is absence of the tubes that carry the sperm out of the testes. So these patients have what we call non-obstructive azoospermia. Okay, so in that cases, in these specific diseases, usually they are not screened to all patients. Usually the doctor, because they are having also other signs, or we can suspect them by other signs, so the doctor has to request the specific genetics test after the clinical suspicion for this specific disease, that apart from other signs, they can have also infertility. And the same happens for females. Females can have abnormalities in the karyotype that you can easily detect by a karyotype in blood. Also, a test that is usually requested in patients with premature ovarian failure is the Fragile X test, detecting, analyzing the gene FMR1, because premutated, this gene is also related with Fragile X syndrome, and premutated women have an increased risk of premature ovarian failure. So usually when a patient is having this sign, premature ovarian failure, the doctor is requesting karyotype and also the Fragile X test. Also, there are another rare genetic diseases that, apart from other signs, can cause or give to the patient infertility. So to conclude, I want the message to take home is the karyotype is a strongly recommended test for infertile couples and couples with multiple miscarriages. In fact, a lot of clinics, they are doing karyotype as a routine test before starting any IVF treatment. But this test is especially recommended for male with abnormal sperm parameters and women suffering from primary ovarian dysfunction or insufficiency. Also, additional tests can be required, such as Y chromosome microdeletion in male or Fragile X in woman. Performing the karyotype gives us valuable information that can impact on the management and treatment of the patients. For example, in case of one of members of the couple is carrier of a structural rearrangement, a structural abnormality, if they have a natural conception, we have to recommend them to do a prenatal testing in order to, or it's recommended to do a prenatal testing in order to detect if the embryo is balanced or it's a balance, okay? Or if they are doing IVF, it's recommended to do a pre-implantational genetic diagnosis, meaning to test the embryos before transfer them in order to see if they are balanced or unbalanced, okay? If they have the balanced form of the translocation or they are abnormal and transfer only the normal ones. For numerical abnormalities in one member of the couple, for example, if we have a Klinefelter patient, they can benefit from testicular sperm extraction and later an IVF with ICSI. The success rate of sperm retrieval in these patients is variable. And in about half of the couples that they do an IVF and they achieve pregnancy. Also, these patients can benefit from testosterone replacement therapy, etc. In cases, for example, we detect a Turner syndrome and 45X patient, we can offer them egg donation. They can be mothers with egg donation, and also they can benefit from strong estrogen replacement therapy, etc. Also, it's very important detecting the abnormality, because this abnormality can be relevant for other members of the family that are at risk, because if you detect a carrier, their brothers and sisters, they are at risk also of having the same translocation. So this allows us to extend the study to other family members and provide them with a genetic counseling and all the reproductive options they have. So thank you very much for your attention.
Thank you so much, Dr. Carmen, and welcome, Dr. Gautam Allahbadia.
Good evening, everyone. Today, the topic I'm covering is tubal factor in infertility. Essentially, this is a patient-centric webinar. So we will go a little slowly and try to explain in layman's language about the importance of the fallopian tubes in getting pregnant. So let us begin, go straight to the topic. To understand the importance of the tubes, let us see how normal reproduction takes place. So this is a beautiful video that tells you this is the surface of the ovary that you see on the screen, and the top is the release rate that is released from the surface of the ovary. And normally cycling hormone releases 1 egg each month. Egg is picked up by the end of the fallopian tube, and there are certain hair-like structure inside the fallopian tube called cilia. This is the cilia which push the egg from the outside to the mid portion of the fallopian tube. With the help of these movements, the egg is pushed and then it lies waiting in the mid-axillary portion of the fallopian tube, waiting for the sperm to come up and fertilize the egg. These are the seminiferous tubulars, and here are where cells are produced that and they make their way from the prostate up to the pedicellus and activate ducts to fertilize the rectum. And the sperm has to be away after man evacuates the vagina from the mouth of the uterus, upper uterine cavity, to the internal tubal ostia, or to the mid-axillary portion of the tube, where the egg remember is leaking. So how does it achieve that? The DNA content of the sperm head is basically 100 times magnified. The mid is the mid portion has the mitochondria, and where the energy is called the engine of the sperm. And the tail is like the rudder of a ship, taking the sperm directly to the. This is a microchip camera at the top of your benign event, and this is slowed down to time. It's a slow-mo film where you have that aggregated, and from the urethra then finds its way to the posterior vaginal column. See it entering vagina and enters the posterior vaginal column where it intermingles with the vaginal secretions. And these vaginal secretions at mid-cycle in the fertile period the sperms alive, and the sperms their way from make their way from the vagina to the mouth of the uterus along secretion. So from the vagina, they make their way up to the cervix and then make their and travel to the cervical crypt, and from the cervical crypt they are thrown up in asynchronous waves. So as you can see, the fertilization takes place in the fallopian tube. And if you understand in simple language that you need only 4 things to make a baby. You need eggs, you need sperms, it's obvious. You need the uterus for the pregnancy to grow. But most importantly, you need open and healthy tubes where the egg meets the sperm, where fertilization takes place. And after fertilization, it takes 5 days for the embryo to travel from the tube back to the uterus and implant there. So when we investigate for these 4 things. So today the topic is tubal factor. The simplest investigation when you are evaluating the egg, sperm, uterus and tube, we come straight to evaluating the tubes. So we do a simple test called the X-ray hysterosalpingogram, where a radio-opaque dye is injected into the uterus with a thin catheter, and you have, this is the uterus outlined, and you have both the tubes with a normal spill. So here, this is absolutely normal HSG. All 3 HSGs here are normal, where the injected dye outlines the uterus as a normal uterine cavity. The dye entering the fallopian tube, you can see the whole length of the fallopian tube. So this is a simple screening test to know that the tubes are open. Any sort of infertility treatment, be it ovulation induction, controlled ovarian stimulation, or any therapeutic intervention like IUI should never be done before ascertaining that the tubes are open. Only if the tubes are open and healthy, then you should go directly for the next step in treatment. So this is just to show you that if the tubes are blocked at the cornu, so here you have the uterus outlined, but the tubes are blocked at both cornu. So this is called a bilateral cornual block. So the tube can be blocked at the starting point where the tube starts from the uterus, or the tube can be blocked at the terminal end. If the tube is blocked at the terminal end, usually you have these dilated, diseased, retort-shaped or flask-shaped tubes, which are commonly seen in developing countries like India and large swath of Africa. So this is the picture once the tube is affected by a pelvic inflammatory disease or by tuberculosis. So you have the tube gets closed at the outer end, so the dye cannot escape from the outer end. And as you keep injecting the dye, the tube dilates and becomes a diseased, retort-shaped, flask-shaped tube. Here, if the tube is blocked, the only treatment is IVF after disconnecting the tube from the uterus. So the tubes have to be disconnected from the uterus and removed. And after that, if you do IVF, you have better results. This is another picture of a lead pipe-like tube where you have the tube closed at the end. But if you see, the tube is like a straight lead pipe-like thing. This is again seen in tuberculosis. The beaded appearance of the tube on the opposite side, again post-tuberculosis. You have again tuberculosis, but here you have a partial spill seen. on one side and you have a retort-shaped tube or a flask-shaped tube on the other. Even if some dye leaks out after a tube which is dilated like this, probably the tube has lost its function. You remember the cilia that I showed you that push the eggs. That cilia gets completely damaged, eroded, matted, fused, and the tube becomes functionless. It cannot push the egg and it cannot push the embryo back into the uterus. If you suspect any abnormality in the HSG, then you have to do an evaluation called a laparoscopic examination of the pelvis, along with pushing a dye, a blue color liquid called methylene blue, which is pushed from the mouth of the uterus and exits from the end of the fallopian tube. So this is what all of us want to see: normal, healthy tubes where you inject the dye and it promptly gushes out like a waterfall or a fountain. And this is a very heartening picture. If it comes out very smoothly, then you know that the tube is not only open, it is most probably healthy. What happens if the tube is blocked at the cornual end? You know, many a times you have HSGs that show the tube is blocked at the cornual end. So what does that mean? Should we take the patient directly for IVF? Not everybody can afford IVF. And is there any other treatment? Well, there are treatments, 3 different types of treatment which are followed to open such tubes which are blocked specifically at the cornual end. So we will go over, we have nice videos from our own collection about how we open such blocked tubes in our clinic. So the first video is using X-ray fluoroscopy, where you put in a catheter into the internal tubal ostium and then inject the dye and force it open with pressure. And if you have the pelvis is clean and it is a blocked bilateral cornual block, which is due to a mucus plug or some debris, physiological debris, then when you do this selective tubal cannulation and injecting the radio-opaque dye, and if the tube is otherwise normal, then you have this beautiful picture of the tube opening. This can be done in the radiology suite and takes about 10 minutes to accomplish if you have a good radiology facility in your city or clinic or hospital. What I prefer is something that we can do along with the laparoscopy. So with the laparoscopy, you can find out if the rest of the pelvis is normal.
This is the hydrophilic glide wire. If you noticed in Vishwanath's case, he had a curved tip glide wire, and this is a straight glide wire. I'm going to introduce this through this Labotech cannula. Isko deela karo.
So this is me
Okay.
a live workshop.
Okay.
In front of 5,000.
There it goes. Can you see bahar ka picture bada karo?
So I have cannulated a tube.
This is the simplest according to me. And another advantage is that if you have a hysteroscope, okay, Prema, can you elevate it? Can you elevate the uterus or the tube? Okay, this is a method we have devised at the Bombay hospital itself. It just takes a few minutes. That is the tube, that's the cannula coming out. And in difficult cases, you can just use hysteroscopic guidance to localize the internal tubal ostium.
So this is how we cannulate the tubes at the time of laparoscopy. And you can open if something is just blocking like mucus or
this is the
blocking it. And you can also do this simply with enough experience using less traumatic catheters and only hysteroscopy. So here we are using a used embryo transfer catheter, which is re-sterilized, and the same hydrophilic glide wire, and trying to cannulate the internal tubal ostia from the uterus. And you just have to go past the mucus plug or debris. Once you do that and you can push in the hydrophilic glide wire, everything becomes very simple, and it's a 2-minute job to open a bilateral cornual block. If you are unsuccessful, then anyway, the final common pathway. So you can have a laparoscopic check to see from the hysteroscope, you have pushed in the glide wire, and from the laparoscope, you can see the tube coming out, bypassing this coronal end. And besides the HSG today, you have something called the cyan test or sonosalpingography,
Seen
which I had
absolutely
published
clearly
in
has been
1990 in
described
the
as
Australian
the waterfall
Journal.
sign,
So we inject a mixture of air and
because
saline,
it
and
does
just with
resemble
vaginal
a waterfall
ultrasound, the
on
gynecologist puts
transvaginal
us in the room
sonography
or suite. You
in
have
a
a mixture of
patient
air and normal
with the
saline
sign
coming out,
seen
and you
as
can find
clearly
out
on
if
both
the
sides
bilateral
as is shown in
is
the film.
open or closed.
It is now seen.
And if there is a bilateral corneal block, and you again put in a pediatric Foley catheter and
And
inject
if the
saline,
reflux
you have to
as
watch for
seen
the stem of the
clearly in
Foley
the stem of the
catheter.
Foley's in this
And
clipping
the
is
faster you
seen
inject, the
for
faster will be the
certainty,
reflux, and the
and
patient will complain
the
of
faster you inject the saline in,
So
the
with
faster it
ultrasound,
goes
simple
back.
vaginal
Then
ultrasound,
it is definitely a
catch the
case of
reflux and know that
bilaterally.
it is a bilateral corneal block. So instead of HSG, going to a radiology suite, you can also do this in your own rooms.
And if
there is, the tubes are blocked, but you suspect there is a history of previous laparoscopy with adhesiolysis, and you want to know the level or the quantity and quality of adhesions,
essentially
then you can just
you
fill up
see
the
a flimsy
saline either through the
adhesion
posterior cutting
which
sac or
moves with the
suprapuvically.
movement of the
Put
probe.
300 ml of saline into a
This
vaginal
is
ultrasound, and this
These
whole
are a
negative
series of
contrast
clippings where all different types
the
of
long
adhesions are
all that
seen
means
clearly.
is that you can
Some are
quantify the
filmy,
adhesion
some
inside
are thick,
the patient
and with the
will be
movement
taken
of
up
the
for
probe,
another
they are
laparoscopy
akin
or
to
should
the
be
movements
directly
of a
referred
fish
for
underwater.
IVF.
The
These
cursor
are
presently is pointing out a filmy
paratubal
adhesion
adhesions, pelvic wall
on the
adhesions, and
lateral
you can
pelvic
also
wall
see
as well.
the entire length of the end of
Essentially,
the
the
probe
principle of
and
this
the
test is that you
fallopian
fill
tube
up the
fimbrial end that
pelvis
can be
with
seen.
saline.
This we
Once the
published in
pelvis is filled with
1992.
saline, that means you create an artificial pelvic ascites and then do a routine transvaginal scan. You can see the peritubal and periovarian adhesions quite clearly, like
And then you have radio opaque dyes which are seen on ultrasound as compared to the X-ray. So you have these ultrasonic contrast media which is similarly injected from the mouth of the uterus, and you the entire
EcoVest is a solution of microparticles of
where you can see the
galactose.
entire
Now this contrast media is a positive contrast media as compared to saline, which we would describe as a negative contrast media. Here a small amount 2 to 5 ml of this positive contrast, if injected as shown here, we can see the uterine cavity, the intramural portion of the tube, the isthmic region of the tube, and you can trace the ampullary region and also the fimbrial end coursing over the ovary, and you see something akin to a waterfall sign around the ovary as seen just now.
And if indeed the tubes are blocked and bilaterally damaged, if you have one patent normal tube, you can get pregnant, with ovulation induction, IUI, controlled ovarian stimulation, or even planned intercourse at home. But if both the tubes are blocked, then the only option is IVF. For people who don't know how IVF is done, let us watch this short film which shows you how egg retrieval is done. We remove the eggs vaginally from a stimulated ovary, and the husband gives the sperm sample on the day of the egg retrieval. We mix the egg embryos, grow the embryos, take time, and then later on do an embryo transfer the following month. So the needle very early on vaginal ultrasound goes from follicle to follicle. The fluid-filled areas include each follicle contains one egg. Both the tubes are blocked. The only option is IVF. The eggs are handed over to the lab, and then after 24 hours, when they put the sperm and egg together, you watch how life begins.
first cleavage takes place after approximately 24 hours. During the first cleavage stages, resulting into up to 8 to 16 cells, each cell is an exact copy of the others and can move freely within the fertilized egg. At the next phase, the cells are bound together into a cell cluster. Now they also start to differentiate in specific ways towards their future functions. What's called a blastocyst moves out into the uterus 4 to 5 days after fertilization.
And it is the blastocyst that we prefer transferring in the month following the IVF. And this is how an embryo transfer is done under transabdominal ultrasound control. This clip, you will see the ultrasonic catheter coming up from the cervix to the top of the uterine cavity. And there is the catheter, embryo transfer catheter, making its way from the mouth of the uterus under guidance to the top of the uterus, about 1.5 centimeter from the fundus. The embryos with the culture media and air are pushed. These white dots are the embryos and the catheter is removed. If you have missed it, let's watch it again. It's a very fascinating clip. This is how an ideal embryo transfer should be done, where you deposit the embryos precisely at the place where you want to deposit them. So here the white dot is the embryo with the culture medium and air, and the catheter is removed. And like all procedures, IVF or with tubal factor infertility, if the tube is damaged, if the cilia inside are damaged, even trying at home or with fertility drugs, you can have this dreaded complication where the pregnancy implants in the tube. Remember, fertilization takes place in the tube and the embryo has to travel back to the uterus.
Ladies and
So if the
gentlemen,
cilia are damaged, the embryo
this is a
cannot travel
case
back.
of a lady
It's
who
trapped
had an
in the
IUI
tube
with
and starts going there.
hyperstimulation
The
in
tube
view
can
of
expand
polycystic
only
ovarian syndrome.
for a few weeks, and then
She
the
later
tube
had a positive
ruptures.
pregnancy
If
test
a blood vessel
with rising
ruptures
beta
along,
HCG titers.
which runs along the tube, you can have
However,
life
no
threatening
intrauterine sac could
emergency
be
called
seen. In
ruptured
fact,
ectopic
bilateral
pregnancy.
adnexal
And
masses were
then
seen.
the treatment is
We
a
therefore put in the
laparoscopy
laparoscope,
with
and
removal of this
as you can
diseased
see,
tube and
we saw a left
or removal of
hematosalpinx
only
initially, which we assumed was a
decide
left
depends
tubal
on the
ectopic
surgeon
pregnancy.
and the extent of damage
Then
to
we
the tube.
tried to see the right side.
So
As you can see, the
if you
right
do
side
get an
was
ectopic
quite
pregnancy,
convoluted, or the
and
femoral
9
end
out of
could be
10 women
seen,
will undergo
and the
this
tube
procedure. So
seems to have
that is a
torted on
laparoscopic
itself.
removal of
We
topic
then
and
tried
cleaning of
to
the blood
restore the
clots and
anatomy
cleaning of the
as
pelvis
is
with
seen
normal
now.
saline. But this thing can also be done
Yet
using, if you have the skill set and you are highly trained. So these are my own series where we treat ectopics by vaginal ultrasound. So you don't have to undergo the more invasive laparoscopy, and this can be done with short propofol anesthesia. And you have, this is a live ectopic 8 weeks. So what we do is we put in a needle with vaginal ultrasound guidance, and we aspirate the amniotic fluid around the baby so it moves less. Then the needle toothpicks the cardiac region of the live fetus, the ectopic fetus, and we inject potassium chloride, which is a chemical or a drug which stops the fetal heart. It causes cardiac arrest, and then we withdraw the needle into the amniotic sac and then inject another medicine, a medicine that stops the growth of cells. It's called methotrexate, which is also used for cancer treatment. So we inject a small, usually 1 milligram per kg body weight of methotrexate is injected in the ectopic sac, and this helps in the early absorption or resorption of the sac. So you don't have to undergo the invasive laparoscopy, and you can save the tube. You know, the body heals in about 3 months' time, the tubes heal. And when we do HSGs following this procedure, most of the time the HSGs are normal. So this is the ultrasonic way of treating an ectopic. And so we have in a nutshell actually covered almost everything that you want to know about how to treat the tubal factor in infertility. So I'm ready for questions for the doctors. These are some of the books amongst the 33 textbooks that I have edited or written, and they're all found on Amazon. And please, search for them. There is an entire tube on the entire book called the Fallopian Tube that you can find on Amazon, and it's got everything you want to know about tubal infertility.